Hello everyone. Welcome back to the series of lectures in neurology. Now we'll be moving on to this group of disorders, which is your movement disorders, under which the most important one is your Parkinson's disease. So let's begin. So Parkinson's disease is the second most common neurodegenerative disorder, second after Alzheimer's disease. So the most common neurodegenerative disorder is the Alzheimer's disease. The second most common is your Parkinson's disease. Okay. So the hallmark feature of Parkinson's disease is because of degeneration of the substantia nigra pars compacta of the basal ganglia. So due to certain genetic causes as well as environmental causes, there can be degeneration of the substantia nigra of the basal ganglia. Substantia nigra pars compacta of the basal ganglia, which is basically involved in the production of dopamine. Okay, so there is decreased production of dopamine and hence this results in a movement disorder called Parkinson's disease. Okay, so there is reduced striatal dopamine and it is also characterized by the presence of inclusion bodies. When you do a histopathological examination, these inclusion bodies are called as Lewy bodies. Okay, so the inclusion bodies found in Parkinson's disease is Lewy bodies. So Parkinson's disease is basically a neurodegenerative disorder which is basically characterized by decreased striatal dopamine. Okay, so there is degeneration of the substantia nigra pars compacta in the basal ganglia. So what are the cardinal features of Parkinson's disease? Okay, so the cardinal features of Parkinson's disease is given by the mnemonic TRAP, right? So TRAP symptoms is very important and they are the four cardinal features of Parkinson's disease. So T stands for tremors. Okay, so T stands for tremors. So can you see in this diagram that there are head tremors, there are hand tremors and there are foot tremors. Okay, what is a tremor? Tremor basically means your alternative movements of your hands and feet is your tremulousness, right? So tremors can be found in the hand, feet as well as head, and this is a characteristic feature of Parkinson's disease. What is the frequency of the PD tremors? The PD tremors are around 3 to 8 Hz in frequency. Okay, the PD tremors are 3 to 8 Hz in frequency. Okay, so the PD tremors are about 3 to 8 Hz in frequency. And how is it different from an essential tremor? An essential tremor is basically a benign tremor, right? So essential tremor is a benign tremor and it is not associated with other features and it has a higher frequency of up to 12 Hz and it can be increased during anxiety and it is predominantly symmetric. Okay, so the essential tremors are usually of a higher frequency and it increases during anxiety and it is more symmetric, whereas the PD tremors are usually of a lower frequency 3 to 8 Hz and they are asymmetric tremors. They are asymmetric tremors. The second cardinal feature, rigidity. The second cardinal feature is rigidity. So what do you mean by rigidity? Whenever we spoke about the tone of a muscle, increased tone, we spoke about spasticity in our chapter on Introduction to Stroke. So spasticity, when you speak about, this is characterized by increased tone. This is characterized by increased tone, but it is a velocity dependent process. It is velocity dependent process. Okay, whereas rigidity is velocity independent. It is velocity independent. Okay, it is velocity independent and the resistance to the movement, is present during both flexion and extension, So in Parkinson's disease also you will have increased tone and this is predominantly a rigidity which is not velocity dependent. Okay, it is more so in your muscles of your axial system. Okay, so that is your rigidity in Parkinson's disease. Okay, also another feature along with the rigidity, you will have something called as cogwheeling. What is the meaning of a cogwheel? So a cogwheel is something like this, right? The old clocks used to have it, and when it moves, it goes and fixes into another one. So it moves slowly like this. So this is a cogwheeling So how do you demonstrate this cogwheeling type of rigidity in Parkinson's disease patients? So you take the patient's hand and you rotate it like this. So this kind of a movement. So because of the rigidity, it will be in a cogwheeling fashion, right? So cogwheeling is also another feature. Then A stands for akinesia. A stands for akinesia. Akinesia or bradykinesia means, kinesis means movement. So they become extremely slow in their movement. Then P stands for postural instability. P stands for postural instability. Okay. So the cardinal features of Parkinson's disease are your TRAP symptoms, which is tremors, rigidity, akinesia and postural instability. Okay. So the other symptoms, can you see here? He has a mask-like faces. It is usually an expressionless faces, a mask-like faces. They have a stooped posture. They have a stooped posture, forward tilt of the trunk, and there is a reduced arm swing. Arm swing when you are walking is basically a function of the basal ganglia. So when there is degeneration, you will have reduced arm swing. There is flexion at the elbows and wrists, slightly flexed hips and knees, and very important, the gait which they have is a short stepping gait. So they walk like this, right? They take short steps and they have a stooped posture and they have a mask-like faces and they have tremorlessness predominantly in the hands and legs, and this is usually asymmetric in nature. So this is an asymmetric tremorlessness, right? So this gait where you have short stepping gait is also called as festinant gait. Okay, it's also called as festinant gait, right? So you have a mask-like faces, festinant gait and TRAP features in Parkinson's disease. Also, when you know that when you ask the patient to turn around, the patient basically turns en bloc, right? They do not turn, there is no smoothness in the movement. So they turn en bloc. Okay, so there is en bloc turning as well. So these are the characteristic hallmark features of Parkinson's disease. Don't forget your TRAP. Okay, so postural instability basically means that they cannot hold a position for a long time, right? Also, Parkinson's disease patients can have autonomic dysfunction and postural hypotension, right? So this is about the cardinal features. Now, let us understand the etiology of Parkinson's disease. So 85 to 90% of the patients have a sporadic form, right? So we do not know the cause actually. Genetic causes for Parkinson's disease usually appears in familial forms of Parkinson's disease. In classical Parkinson's disease, it is usually inherited in an autosomal dominant fashion, and the genes that are involved are the PARC gene, which is your PARC1, PARC8 and PARC17. PARC1 is also called SNCA, PARC8 is LRRK2 and PARC17. When we speak about early onset Parkinson's disease is usually more common at the age group of more than 60 years of age. Early onset Parkinson's disease is usually autosomal recessive in nature, and the genes involved are Parkin gene, PINK1 and DJ1. Also associated are certain toxins like your MPTP toxin, and exposure to pesticides has also been found as some of the etiologies. You would have heard of a term which is called as dementia pugilistica. Okay, dementia pugilistica. So what is this dementia pugilistica? This is basically a Parkinson's disease which is usually of younger onset, and it occurs basically due to repeated trauma to the head as commonly seen in boxers, right? So first it was diagnosed in a boxer. So this dementia pugilistica is a type of Parkinson's disease which is seen in younger individuals, and it occurs due to repeated trauma. Okay, so this is about the various etiologies and the genetic causes for Parkinson's disease. So let us understand the pathogenesis. So what exactly happens and why is there a degeneration of the substantia nigra? Okay, so there is a close interplay of various factors including inflammation, oxidative stress and excitotoxicity via glutamate. We had read of excitotoxicity in ALS chapter as well in your motor neuron diseases. So there is inflammation, there is oxidative stress, there is excitotoxicity, and there is aggregation of abnormal proteins probably due to a genetic predisposition also secondary to certain environmental causes. Right, so when these abnormal proteins aggregate, they cause inflammation, excitotoxicity, oxidative stress, and finally resulting in mitochondrial dysfunction as well. Now, all these factors put together contribute to the cell death in the substantia nigra pars compacta. Okay, so this finally leads to neurodegeneration or degeneration of the substantia nigra pars compacta, and there is a reduced production of dopamine. Let us understand the basal ganglia pathways and the physiology of basal ganglia before going on and trying to understand how exactly this Parkinson's disease happens. Okay, so whenever we come to neurotransmission in the basal ganglia, there are two pathways. Okay, so before we understand what exactly is Parkinson's disease, let us understand the basic physiology of the basal ganglia. So when it comes to the basal ganglia, there are two pathways that are involved, which basically includes the direct pathway and the indirect pathway. So the neurotransmission in the basal ganglia involves two pathways, the direct pathway, which is excitatory in nature, and the indirect pathway, which is inhibitory in nature. Okay, the direct pathway, when it is activated, it acts on the agonistic muscles, and the indirect pathway basically acts on the antagonistic muscle. Right? So the whole point of this direct pathway and the indirect pathway is that through the direct pathway it excites the agonistic muscle, and through the indirect pathway it inhibits the antagonistic muscle. So there should be excitation of an agonistic muscle and inhibition of the antagonistic muscle for a smooth movement, right? So this is what your substantia nigra does. So the substantia nigra via D1 receptors, D1 basically refers to the dopamine 1 receptors. It causes stimulation of the direct pathway, and via D2 receptors, it basically causes inhibition. It causes inhibition via the indirect path. Okay, so there is stimulation of the agonistic muscle and inhibition of the antagonist. This is the basic funda of your basal ganglia path. Okay, fine. Concept number 2. Concept number 2 that you should understand is whenever you are seeing your pathways in basal ganglia, always understand that the striatum, which comprises of the caudate nucleus and the putamen, the striatum, which comprises of the caudate nucleus and the putamen, is the receiver and always supplies to the globus pallidus. Okay, so the striatum is always the receiver and it always supplies to the globus pallidus. Okay, fine. Concept number 3, just remember these 3 important points. All pathways are inhibitory except the one with the subthalamus. All intrinsic pathways are inhibitory in nature. Okay, so basically when you go through the pathway, all the pathways are inhibitory in nature, right, except the output of the subthalamus. Okay, so let us understand the basics again. The 3 concepts that you have to understand are: direct pathway is excitatory, and direct pathway is excitatory to the agonistic muscle. The indirect pathway is inhibitory to the antagonistic muscle. Okay, the striatum is always the receiver and it gives its output to the globus pallidus. Fine. And all intrinsic pathways are inhibitory in nature except subthalamus. Fine. Okay. Now let us understand the direct pathway first. Okay. So what are the steps in your direct pathway? So the cortex, whatever is in green is excitatory, whatever is in red is inhibitory. Okay. So the cortex basically causes stimulation of the striatum via glutamate, which is an excitatory neurotransmitter. Okay. So the cortex is stimulatory to the striatum, right? And we told you all intrinsic pathways are inhibitory. So the striatum is inhibitory to the globus pallidus, correct? The globus pallidus is inhibitory to the thalamus. Okay? The striatum is inhibitory to the globus pallidus and globus pallidus is inhibitory to the thalamus. So all intrinsic pathways are inhibitory except that of subthalamus. Then always remember, the striatum is always going to be the receiver from the cortex and it is always going to go and give its output to the globus pallidus. Can you see that? That the striatum is the receiver from the cortex and it gives its output to the globus pallidus. Alright? And then the thalamus is excitatory to the cortex. So excitation, inhibition, inhibition, excitation. Clear? Right? So it is very, very clear here. Now let us understand what happens when the direct pathway is activated. So there is an impulse which comes here. There has been an impulse which comes like this. Okay, so there has been an impulse which comes like this, and it causes activation of the cortex. Now the cortex, once it is stimulated, it is going to cause activation of the striatum, which is the receiver, right? So this is the molecule or the impulse which is causing activation of the cortex. So it is going to, when the cortex is activated, it is going to activate the striatum. The striatum is activated or inhibited? Activated. Okay, so the striatum is excited or activated. Now, once the striatum is activated, it is inhibitory to what? It is inhibitory to your globus pallidus, right? So when the striatum is excited, what is going to happen to the globus pallidus? The globus pallidus is going to get inhibited. Okay, it's clear till here? Now, here is where the catch comes. Please try and understand very, very carefully. Now, the globus pallidus has an inhibitory effect on the thalamus. Right? This is what we learned here. Can you see it is in red? Globus pallidus has an inhibitory effect on the thalamus. Now, the globus pallidus is already inhibited. So, the inhibitory effect on the thalamus is lost. Rather, there is a disinhibition. So, the thalamus in fact gets activated or excited. Okay. So, inhibition of inhibition, right? There is, so the globus pallidus has an inhibitory effect on the thalamus, but already the globus pallidus is inhibited. So, there is disinhibition, and hence the thalamus becomes excited. Okay, the thalamus becomes excited, and this is going to cause excitation of the cortex thereafter. Right? So, the thalamus becomes excited and it is going to cause excitation of the cortex thereafter. Right? So, excitation of the cortex is your direct pathway, and this is your direct pathway. Fine. Now, let us look at the indirect pathway. How is the indirect pathway different from the direct pathway? Because there is involvement of the subthalamic nucleus and there is involvement of the globus pallidus interna as well. Right? So, the cortex is stimulatory to the striatum. This we know. Then after the striatum, all intrinsic pathways are inhibitory except that of subthalamic nucleus, right? So, the striatum is always the receiver and it always goes to the globus pallidus. So, striatum is going to inhibit the globus pallidus externa. The difference comes here because it takes a detour. It does not go to the thalamus. It goes to the subthalamic nucleus, then it goes to the globus pallidus interna, and then goes to the thalamus. So, this detour is what is your indirect path. Okay, so again, all intrinsic pathways are inhibitory. So, the globus pallidus externa is inhibiting your subthalamic nucleus. Which is the exception? It is your subthalamic nucleus. So, subthalamic nucleus is excitatory to your globus pallidus. Subthalamic nucleus is excitatory to your globus pallidus interna. Again, the output from globus pallidus interna will be inhibitory, right? All intrinsic pathways are inhibitory. So, globus pallidus interna is again inhibiting your thalamus, which is going to stimulate your cortex. Okay, so it's very, very clear. So, the odd point that you have to see is this we have already discussed, and the detour that it is taking from globus pallidus externa to subthalamic nucleus to globus pallidus interna to the thalamus. Now, let us understand when the indirect pathway is stimulated, how do you get your output? So, your indirect pathway is stimulated, right? So, this is your indirect pathway. The cortex is stimulated, so it is going to go to the receiver. Which is the receiver? The striatum. Striatum is excited, right? Now, the striatum is excited, it is going to inhibit what? The globus pallidus externa. So, the globus pallidus externa is inhibited. Till here we are very clear. Now, let us understand. Now, the globus pallidus externa is inhibitory to the subthalamic nucleus, right? So, now the globus pallidus externa is inhibited. So, the inhibitory effect is lost, right? So, what will happen to the subthalamic nucleus? The subthalamic nucleus is going to get excited, right? So, this becomes very, very simple, similar to how your thalamus was getting disinhibited. Here, your subthalamic nucleus is getting disinhibited. So, I hope this is very, very clear. The inhibitory effect of the globus pallidus externa on the subthalamic nucleus is lost, and hence the subthalamic nucleus gets excited. There is disinhibition here. Now, let us understand further what is happening. Now, this is already excited. This is already excited. Now the output of subthalamic nucleus is an exception. It is going to be excitatory. So the globus pallidus interna is going to get excited again. It is going to get excited again. Now this is inhibitory to the thalamus. Now since it is excited, the thalamus will be inhibited, right? The thalamus will be inhibited and hence the cortex will also be inhibited, right? So the thalamus is inhibited and the cortex will also be inhibited. So this is the whole difference between your direct and your indirect pathway. So disinhibition happens in the thalamus at the direct pathway. In the indirect pathway, it is your subthalamic nucleus. So ultimately, the direct pathway is increasing your contraction of the agonistic muscles, right? And the indirect pathway is going to inhibit your antagonistic muscle. Okay, fine. So in your Parkinson's disease, what happens is there is a loss of your substantia nigra cells, right? Substantia nigra, which is present in your basal ganglia. So striatal dopamine is going to get lost. So the problem is going to come at the level of the striatum. So the coordination of your agonist antagonistic muscles is going to get lost. Okay, so this is very, very clear. Now let us understand the clinical features of Parkinson's disease. We have already looked at the cardinal features. Let us understand what are the clinical features. Cardinal features is what? It is trap. We have already seen resting tremors, rigidity, bradykinesia or akinesia, and postural instability. Always remember about the tremors in Parkinson. They are usually resting tremors, and when you do intention, right, you ask them to do a movement like how you check for cerebellar signs, they do not have intentional tremors. With an intention, usually the tremorlessness reduces. So it is at rest that they have this tremorlessness. Okay, so resting tremor, rigidity, akinesia, postural instability are your cardinal features. Let us see other features. Very, very important. When you ask them to write, it becomes like this. What is this? There is micrographia, right? So there is micrographia. Where do you find macrographia? Macrographia is seen in cerebellar disorders, right? So macrographia is seen in cerebellar disorders. So there is micrographia. Mask-like faces, they do not have expressions at all. So hypomimia or mask-like faces, there is reduced eye blinking, there is drooling, hypophonia, there is freezing of gait. If you ask them to walk, they have a slow shuffling gait, festinant gait that we saw. But suddenly there will be a freezing of gait and they will not be able to put the next foot forward. This is called as freezing of gait. Freezing of gait is another very important feature of Parkinson's disease, and they may have recurrent episodes of fall as well, and they usually move en masse, right? So if you ask them to turn, a normal individual will turn easily, but a Parkinson's disease patient will turn en bloc. They turn like this. All right, fine. Okay. What are the non-motor features? Very, very important that though this is a movement disorder, though this is a hypokinetic disorder, there are certain non-motor features that we should be aware of. One is anosmia. Then sensory disturbances. They have a lot of non-specific pains. They can have associated mood disorders like depression and sleep disturbance, where you have fragmented sleep, and REM sleep behavioral disorders. Very, very common. Also, they can have restless leg syndrome, right? So they have a lot of sleep disturbances. Another very important point that you have to remember is the presence of autonomic disturbances, right? So another very important point is the presence of autonomic disturbances, predominantly orthostatic hypotension. Gastrointestinal disturbances can result in diarrhea or constipation, more predominantly constipation. Genitourinary disturbances, right? So it can result in genitourinary and sexual disturbances as well. And cognitive impairment and dementia can happen in the later stages. Okay, so this is about the various clinical features of Parkinson's disease. Now, whenever you examine a patient with Parkinson's disease, there are certain clinical tests which help you clinch the diagnosis of Parkinson's disease, right? So what are the clinical tests? One is pull test. So in this pull test, what do you do? This is the patient and he is facing this side, and the doctor who is there is going to pull him backwards. Okay, so the doctor is there going to suddenly pull him backwards. and someone who is normal will move back maybe around 2 to 3 steps, and after that he gains his stability. But a Parkinson's disease patient, because of postural instability, he will continue to move backwards and even fall down. So this pull test is positive in patients with Parkinson's disease. Then Foreman's sign. What is Foreman's sign? Right? So Foreman's sign basically means that you ask them to do a movement in one hand or one limb, maybe like a movement like this, right? The other hand, the tremors is going to increase. So there is increase tremors on the contralateral hand of movement, right? So that is called as your Foreman's sign. Then glabellar tap. Glabellar tap is basically indicative of a frontal release reflex. Okay, glabellar tap is basically indicative of a frontal release reflex, right? So glabellar tap is indicative of a frontal release reflex. So whenever you tap on the glabella, usually the blinking will not continue for more than about 5 to 10 times once the patient gets used to it. But here the glabellar tap sign is positive. The patient continues to blink how many ever times you tap on your glabella. Then you have to demonstrate rigidity by your cogwheeling. Okay, you have to demonstrate rigidity by your cogwheeling. So this is about the various clinical tests that can be used in the diagnosis of Parkinson's disease. So what are the differential diagnoses of Parkinson's disease? So a patient comes to you with rigidity, tremors, akinesia. What are the other things that you can think of? You have to think of atypical Parkinson's disease, right? Atypical Parkinson's disease is a differential diagnosis. Always remember certain secondary causes for Parkinson's disease before classifying them as idiopathic PD. Drugs, most importantly, your antipsychotic drugs. Yeah, why do these antipsychotic drugs cause PD? Because they also cause depletion of dopamine. They cause depletion of dopamine and you can have Parkinsonian side effects. Then trauma, tumor, infection, NPH toxins like MPTP and carbon monoxide, all of these are causes of secondary PD. Then always remember that if a patient is coming with Parkinson's disease, never forget to check up for the other associated conditions which Parkinson's disease can be found with, including your Wilson's disease, Huntington's disease, spinocerebellar ataxia, Fragile X syndrome, Alzheimer's, then dopa-responsive dystonia. All of these can be associated features with Parkinson's disease. So please don't forget to examine for all of these other features. So this is about the differential diagnosis. Now, what is atypical Parkinson's disease? Atypical Parkinson's disease is also called as Parkinson Plus Syndromes. Okay, atypical Parkinson's disease is also called as Parkinson Plus Syndromes, right? So when do you suspect your atypical Parkinson's disease? Okay, so atypical Parkinson's disease usually comes at an age group which is less than 40 years of age. It is usually coming at an age group less than young onset Parkinson's disease, less than 40 years of age, and it has poor response to levodopa. Okay, so age group less than 40 years of age, poor response to levodopa, then you will suspect atypical Parkinson. It is not your classical degradation of substantia nigra. There can be something else that is going on. Alright, fine. Also, let us look at the other signs and symptoms. Early speech and gait impairment. Early speech and gait impairment is not commonly seen in PD. We had seen that there are only the trap features which are the cardinal signs. Early speech and gait impairments and lack of tremulousness and more symmetrical tremors. If the tremors are more symmetrical, right? Because we told you that tremors are usually asymmetrical in PD. Symmetrical tremors, think of atypical PD, right? Lack of motor asymmetry, early falls, increased falls, right? Early falls you consider atypical Parkinsonism, right? So these are the features with which you will consider atypical Parkinsonism. Now we have spoken about the differential diagnosis, right? So what are the other things that you will consider? So exposure to neuroleptics, you think of drug-induced PD that we had discussed, antipsychotics. Then onset less than 40 years of age, again atypical Parkinson's disease, Wilson's disease, dopa-responsive dystonia. If there is associated liver disease with Parkinson's, then definitely think of Wilson's disease. Then early hallucinations, dementia. Early hallucinations and dementia. Think of dementia with Lewy bodies. Dementia with Lewy bodies is also similar to PD. PD also has Lewy body accumulation. Dementia with Lewy body, DLB also has Lewy body accumulations. Then diplopia, impaired vertical gaze, all of these are nothing but atypical Parkinson's disease. Okay. So these group of disorders, which is your Parkinson Plus Syndromes, we will be discussing separately. But you should be knowing when do you suspect, right? When do you suspect? These are the most important points. Lack of asymmetry, poor response to levodopa, young onset, more symmetrical process, increased falls, right? Hallucination and other kind of other atypical symptoms, you think of PD, atypical PD. Alright, fine. Now, how do you diagnose your Parkinson's disease, right? So, this is basically a coronal section of the brain. This is your caudate nucleus. This is your caudate nucleus, and here you have your thalamus, and this is your substantia nigra and your substantia nigra and your subthalamic nucleus. So, this is your caudate, this is your substantia nigra and subthalamic nucleus, and here you have your thalamus, and this is your globus pallidus. Okay, this is your globus pallidus, and this is your putamen. Okay, so these are the basic structures in your basal ganglia. So you have a major problem here in your substantia nigra. Okay, so whenever you do an MRI, these structures basically give rise to something called as a swallowtail appearance. An absence of swallowtail sign is a characteristic feature on MRI suggestive of Parkinson's disease. Okay, that is one. The next test that you can do is a dopamine based brain imaging, where a brain dopamine imaging indicates that there is decreased dopamine production from your substantia nigra, then you know that there is degeneration at that site. Apart from that, PET-CT and single photon emission computed tomography can also be used, and genetic testing can be done. We saw all the genes, right? So genetic testing also can be done, especially in familial onset Parkinson's disease. So this is about your diagnosis. Now let us move on to the treatment of Parkinson's disease. So the first discovered and the most useful drug in the management of Parkinson's disease is your levodopa. Okay, so the first discovered and the most useful drug is your levodopa. Apart from this, we have other groups of drugs including dopamine agonists. What are the examples of dopamine agonists? They include ropinirole, pramipexole, apomorphine. Okay, ropinirole, pramipexole and apomorphine. The next group of drugs is your COMT inhibitors. COMT inhibitors include entacapone and tolcapone. Okay, COMT is carboxymethyl-transferase, which is basically responsible for the breakdown of dopamine, so you inhibit that. Then we have MAO-B inhibitors, example is salicylic. The newer drug which includes your adenosine 2A inhibitor. This is adenosine 2A inhibitor, which is called as estradiol, and the other drug is amantadine. Okay, so these are the various drugs used in the management of Parkinson's disease. The earliest and the most effective of the ones till date has been levodopa. Now let us look at each of the drugs one by one. So first is levodopa. So what is the mechanism of action of levodopa? Right, so dopamine is the one which is deficient in Parkinson's syndrome. Right, so you give levodopa, which is basically a precursor, of dopamine. So it is a precursor of dopamine that crosses the blood-brain barrier. It's a precursor of dopamine that crosses the blood-brain barrier and hence increases the levels of dopamine in the brain. So this is the basic mechanism of action of levodopa. Okay, but levodopa has a shorter half-life. So it has a shorter half-life, and hence to prolong its action, we give a peripheral decarboxylase inhibitor. To prevent the breakdown of levodopa. That is called as carbidopa. So this levodopa plus carbidopa is what we call as duodopa. Okay, levodopa plus carbidopa is called as duodopa, or we give it under the brand name of syndopa. Okay, and how do you give it? You give it up to 3 to 4 times per day, because its duration of action is only about 3 to 4 hours. Right, so you will have to give it about 3 to 4 times a day. Then long-acting preparations of levodopa are also available, and levodopa can be given as a levodopa intestinal gel. Right, the most commonly used one is your levodopa with carbidopa combination, which is your syndopa. Fine. So what is the mechanism of action we have understood? Now how does it improve the symptoms? So the main symptom improvement is in the form of decrease in your motor symptoms. It improves your gait, it improves your walking. Okay, and it also has effect on certain non-motor symptoms. The non-motor symptoms where levodopa is useful is decreasing anxiety, depression, and your autonomic side effects like sweating. Right, so main function of levodopa is that it helps in overcoming your motor symptoms, but it has small effects on your non-motor symptoms as well. Okay, so whenever we speak about levodopa, what are the important points we have to remember? Levodopa was the first, and it is the most useful drug in the management of Parkinson's disease. Okay, so levodopa basically is a precursor of dopamine. It crosses the blood-brain barrier and increases the dopamine levels in the brain. So it is like a dopamine replacement therapy. Okay, so because of its short half-life, it is combined with carbidopa. Okay, fine. Let us understand what are the side effects of levodopa. The side effects include nausea, vomiting, and hypotension. Right, but the most important with respect to your Parkinson's disease management is this presence of fluctuations in motor symptoms. Okay, so there are fluctuations in motor symptoms with the use of levodopa. There are fluctuations in motor symptoms with the use of levodopa. So what are the fluctuations? The first one is what is called as a wearing off effect. Right, so the first one is what is called as the wearing off effect. That means that over the course of time, over prolonged use of levodopa, the effect of levodopa does not last for your 3 to 4 hours, rather it wears off little early, and this is what we call as the wearing off effect. Second is something called as on-off phenomenon. What is the meaning of on-off phenomenon? So on-off phenomenon basically means that the drug is working. The drug is working during the on period, and suddenly it stops working. Okay, and this is what we call as the off period. Right, so that means when the drug is working during the on period, there are no motor symptoms, and suddenly the drug stops working. Right, so you would expect that the duration of levodopa action would be for about 4 hours, and suddenly there is a wearing off of your levodopa effect and the motor symptoms begin to appear again. So they keep switching between on and off. Right, so when the drug is on, there are no motor symptoms. Drug is off, there are motor symptoms. So this kind of a fluctuation between on and off is very, very problematic to the patient, because they will not be able to carry out their activities well. So this on and off phenomenon is also another important side effect of chronic or long-term use of levodopa. Right, so with long-term use of levodopa, you can have your wearing off effect, you can have on-off phenomenon. So in these kind of cases, if there is a wearing off effect, you may have to increase the dose. Right, you may have to increase the dose. And in on-off effects, what you will have to do is you may have to increase the dose again, or you give a combination therapy. Okay, then third important side effect or issue with your use of levodopa is something called as peak dose dyskinesia. Okay, so what does that mean? So in a patient of Parkinson's disease, so this is your drug levels, this is your drug levels, and this is your dyskinesia. So when the drug level increases, the drug level is your maximum drug level, and here you start getting coriform movements, dystonias, myoclonus, which are in fact not there in Parkinson's disease, but it is a drug related side effect. So peak dose dyskinesia is characteristic side effect of long-term use of levodopa. Right, so you have coriform dystonic movements, myoclonic movements. 4. You can have low dose dyskinesia as well. Okay, low dose dyskinesia means that the drug level has not yet reached its peak. It's somewhere here or here. That means in the stages where the drug begins to act or ends to act, right? So now I have taken the drug, immediately I am having a dyskinesia. This is a low dose dyskinesia. Okay, so you get abnormal movements like myoclonus, jerking movements, coriform movements. So these kind of dyskinesias can happen at a low dose dyskinesia. Then during the end, when the drug levels in the body are low, again when the duration of action of the drug is ending. So this is what we call as your low dose dyskinesia, which is diphasic in nature. It can happen during the beginning of the drug administration or end of the drug administration. Okay, fine. So this is usually characterized by transient stereotypic rhythmic movements can be present. Okay, so this is about the various motor fluctuations which you can get with long-term levodopa therapy. So wearing off effect, on-off phenomenon, peak dose and low dose dyskinesias. Okay, fine. So the drug which can be used for the management of these levodopa-induced dyskinesias is your apomorphine. Okay, so for levodopa-induced dyskinesia, what is the drug that is used? It is apomorphine. So apomorphine is the drug used for levodopa-induced dyskinesia. Clear, right? Then another very rare syndrome that you should be knowing with levodopa use or dopamine agonist use. Levodopa use or dopamine agonist use is something called as DDS or dopamine dysregulation syndrome, where the patient usually develops an addiction behavior to dopamine. They have addiction behavior and they have a lot of neuropsychiatric side effects, which is called as dopamine dysregulation syndrome. And a characteristic feature of this dopamine dysregulation syndrome is something called as punding, where they tend to collect objects. They tend to collect objects and they arrange it in order. Right? So there is no reason why they do so. They tend to collect the objects, try to arrange. This is what we call as punding behavior, which is seen in dopamine dysregulation syndrome. Alright, fine. So this is about your levodopa therapy. Now let us move on to dopamine agonists. Okay. So what is the function of dopamine agonists? Dopamine agonists help in decreasing the off time, right? So they can be combined with levodopa and they help in decreasing the off time. However, they are less efficient and they can be used in young individuals. What are the main side effects? Hallucinations. Dopamine agonists can cause hallucinations. It can cause gambling and compulsive disorders. It can cause dopamine dysregulation syndrome as well. So sedations, hallucinations, lot of neuropsychiatric side effects can be seen with dopamine agonists. Then MAO-B inhibitors. What is the function of MAO-B inhibitors? Like your selegiline and rasagiline, they block central dopamine breakdown. Then COMT inhibitors increase the half-life of dopamine and decrease the off time. The main side effects are diarrhea and hepatotoxic side effects, right? Then there is something called as on-demand off therapy, right? So if the on-off fluctuations are more and the off period is more, then we know that we can give dopamine agonists, we can give COMT inhibitors, but they come with their own range of side effects. So you can use on-demand off therapy. That means during the off period, whenever the patient feels that off period is too much, they are not able to handle the off period, when the drug is not acting and the motor symptoms are increasing, you can use on-demand off therapy, which includes inhaled levodopa and subcutaneous and sublingual apomorphine. So the only two drugs which can be used is inhaled levodopa and subcutaneous or sublingual apomorphine. Fine. And the last resort, if there is no improvement in any of the symptoms, would be surgery and deep brain stimulation. Right? You can do a surgery where you remove your globus pallidus, you do pallidotomy, right? Or you can also do a deep brain stimulation. So this is the last resort effect, right? So this is about the different drugs and their profile in the management of Parkinson's disease. Now let us understand how do we approach a patient with Parkinson's disease. So whenever a patient comes with Parkinson's disease for your treatment, it involves non-pharmacologic intervention and pharmacologic intervention, right? So neuroprotection drugs like rasagiline have been tried, but they are not really FDA approved. So then you see the functional disability, right? If there is functional disability is present, then you start with levodopa. The dopamine agonist therapy is usually the first line drug in younger individuals less than 40 years of age. If there is no improvement with this, then you consider combination therapy with levodopa, dopamine agonist, COMT or MAO-B inhibitors, and the last resort will be a surgery. Okay, fine. So this is about your Parkinson's disease. Now, how will you manage the non-motor symptoms, right? How do you manage the non-motor symptoms? Because Parkinson's is not always about the motor symptoms. So patient may have anxiety, patient may have depression. For anxiety, you can give beta blockers. You can give beta blockers. Okay, you can give beta blockers, you can give benzodiazepines as well. So benzodiazepines, beta blockers will help in management of anxiety. Patient is depressed, be very careful with what antipsychotic you are going to use. You may have to give an antipsychotic, or you may have to give a tricyclic antidepressant, but be careful with what drug you are choosing because they themselves have dopaminergic side effects, so you have to be careful about. Then, if a patient presents with dementia, what are the drugs that we have to stop? Always remember, stop your anticholinergic, COMT inhibitors, MAO-B inhibitors and amantadine, and look for whether it is a drug induced or is it because of worsening of the Parkinson's disease. Then remember that the patient can also have a lot of autonomic side effects and postural hypotension, they can have orthostatic hypotension, they can have gastrointestinal disturbances, urinary disturbances. So each of that has to be taken into consideration, right? So in the initial stages of orthostatic hypotension, you give them fluid and salt. In the later stages, you may have to treat them with fludrocortisone and so on, right? Also, they are very much prone to sleep disturbances. So you can give drugs like your melatonin agonist. Melatonin agonist can be given in order to improve their sleep-wake cycle, and they can also have REM sleep disorders, or your restless leg syndrome, where here you can give drugs like primidone. You can give drugs such as primidone. Okay, fine. So this is about the management of Parkinson's disease. Alright, so this is about the management of Parkinson's disease. Now let us move on to atypical Parkinson's disease. Okay, so atypical Parkinson's disease can be classified as the following. So we have multi-system atrophy, MSA, multi-system atrophy, which is again further classified into multi-system atrophy Parkinson type, multi-system atrophy Parkinson type, and MSAC, which is multi-system atrophy cerebellar type. Then you have progressive supranuclear palsy, progressive supranuclear palsy. Then we have CBD or corticobasilar degeneration, right? So we have MSA, we have PSP and CBD. So this is about atypical Parkinson's disease. So when will you suspect atypical Parkinson's disease or Parkinson Plus syndromes? We had just discussed young onset, early speech and gait involvement, symmetrical tremors and no response to levodopa. All these would suggest that there is something else that is going on, which is your atypical Parkinson's. So let us look at each of these disorders one by one. We will start with your progressive supranuclear palsy. Progressive supranuclear palsy is also called as Steele-Richardson's syndrome. Okay, progressive supranuclear palsy is also called as Steele-Richardson's syndrome. Okay, so what is the cause? Most of the time the cause is unknown, right? But there have been studies which have shown that there can be mutations in your apolipoprotein E4. So what are the classical clinical features of progressive supranuclear palsy? There is a downward gaze palsy. So progressive supranuclear, the supranuclear fibers for your vertical gaze is going to be affected. The supranuclear fibers for your vertical gaze is affected. So you have a downward gaze palsy predominantly. So they are able to look up, but they have a problem looking down, as a result of which this results in repeated falls because they are not able to see their feet. Alright, and there is a decreased eye blink rate. You can also have eyelid apraxia. Means, what is the meaning of apraxia? Apraxia means inability to perform a learned motor act. So inability to perform a learned motor act. Right? So in eyelid apraxia, what will happen is if they close their eyes, they are unable to open it, right? This is not because of weakness of the extraocular muscles, it is because of apraxia. So you can have eyelid apraxia. Another characteristic feature, you can have early dysphagias, you can have retrocolisy, backward flexion of the neck, and they have deep inspiratory sighs where reason has not been found. So these are very peculiar clinical features of PSP. Always remember vertical gaze palsy, difficulty in downward gaze, and eyelid apraxia, retrocolis, deep inspiratory sighs. Okay, so this is PSP. So what is the MRI finding? The MRI finding is that there is atrophy of the dorsal mesencephalon. So if you can see here, there is atrophy of the dorsal mesencephalon resulting in a bird-like appearance. This is what we call as the hummingbird sign. This is called as the hummingbird sign. Okay, and the next sign which you see here, right? So there is loss of convexity. There is loss of convexity of the brainstem. It should have been like this. It is lost. So this is what we call as the morning glory sign. This is what we call as the morning glory sign or Mickey Mouse appearance. Okay, morning glory sign or Mickey Mouse appearance. Okay, so these are the two radiological signs that you find in progressive supranuclear palsy. So most of the time they are levodopa unresponsive. They are levodopa unresponsive, and the treatment is usually supportive treatment. Because they have early onset dysphagia, they may require a Ryle's tube. There is a risk of aspiration pneumonia, right? So most of the time we'll have to give them supportive treatment. So that is about your PSP. The next is what we call as multi-system atrophy, MSA. Okay, so these are the types. We have striatonigral degeneration, which is now called as your MSAP because they have more predominant Parkinson's symptoms because of striatonigral degeneration. Then we have Shy-Drager syndrome and olivopontocerebellar atrophy, which is called as MSAC because of predominant cerebellar sign. So the characteristic feature that you have to remember about all types of MSA is this dysautonomia. They have prominent autonomic nervous system dysfunction, severe orthostatic hypertension, tachycardias, history of arrhythmias, right? So this is a very, very important feature of your MSA. Apart from this, they can have myoclonic jerks. They have anti-flexion of the neck. Retrocolis is seen in PSP. They have anti-flexion of the neck. They have dystonias and something called as cold hand sign where the hand becomes blue. Okay, so they have bluish discoloration of the hand with swollen hands because of small episodes of ischemia. So you have something called as cold hand sign. So these are all some of the clinical features of MSA. Remember, MSAC has a lot of cerebellar signs. Apart from this, you can have myoclonus, you can have dystonias. Okay, and what is the characteristic radiological appearance? You can see here, I'll change the color and show you, right? Can you see that in the pons you have something called as hot cross bun sign? Okay, so the sign is called as your hot cross bun sign. So on the MRI, the characteristic feature is your hot cross bun sign. So this is your multi-system atrophy, right? Then apart from this, you can also have a low intensity signal in the putamen, and the putamen can be surrounded by a high intensity signal. So you have low intensity signal in the putamen followed by surrounding of the putamen by the high intensity signal, which is called as putaminal ring sign. Putaminal ring sign. So that's about the MRI findings in multisystem atrophy. Treatment again is no specific treatment. Most of the time they have levodopa non-responsiveness. Then corticobasilar degeneration is characterized by 3 phases. In the early phase, you have an asymmetric clumsiness and myoclonic jerks can be present. In the mid phase, around 3 to 5 years of after starting the disease, you have a dystonic useless arm, right? One arm becomes dystonic. Dystonia means continuous contraction of the muscles can result in a spasm resulting in dystonia. This is a movement disorder. So one arm will have continuous dystonia and it becomes useless. It does not have any functions, and this is what we call as alien limb phenomenon. So, where is alien limb phenomenon seen? It is seen in corticobasal degeneration. You can have apraxias, and you can also have, because of cortical degeneration, you can have cortical sensory loss. You know what are the cortical sensations, right? Tactile discrimination, tactile localization, stereognosis, graphesthesia, all of these are cortical sensations which can be lost. From 5 to 8 years since onset, you can have a widespread frontotemporal dementia as well. Okay, so this is about your corticobasal degeneration. So with this, we have understood the salient features of atypical Parkinson's disease. So with this, we have come to the end of our chapter on Parkinson's disease. So we have understood what is Parkinson's disease, we have understood the pathophysiology, we learnt about direct and indirect pathways, we learnt about the cardinal features of PD, we have learned how to identify the secondary causes for PD and how do you differentiate atypical Parkinson's from typical Parkinson's disease and the various treatment options. Thank you.